So in looking at my patients that I have coming up today on the schedule, one particular patient that I've been working with on his knee pain kind of sparked something that I wanted to talk about, which is why, if you've been in chronic pain and haven't really seen a lot of relief with many of the therapies that have been recommended to you, that insurance has covered, all that kind of stuff, why you need to consider the peripheral cutaneous nerves as potential pain generators and potentially what's contributing to your pain. So within the body, we have different kind of sections of nerves. We've got the central nerves, right? We got the spinal cord plus the nerve roots, and then we've got, the large nerves that are going to be traveling down outwards into the extremities, the femoral nerve, the sciatic nerve, common peroneal nerve, things like that. But as we get out further or closer to the skin, those large nerves start branching out into smaller branches, which then provide actual sensation to the skin. So the reason you can feel things on your skin is because there are nerves that are in your skin that transmit that information up to the brain. Now, sometimes there can be dysfunction in those nerves, and that can be due to different reasons, whether it's a cutaneous nerve entrapment. So we can actually have either through the muscle or the fascia layers, we can have a constriction around the nerve, which then causes an increase in inflammation around that nerve. You could have damaged it in the past. So, everybody knows hitting their elbow, hitting the funny bone, things like that. That can trigger neurogenic inflammation. And then also just chronic friction. So one of the common places we see that actually is in the greater occipital nerve in the back of the skull. When we continually do this, we are getting, right, so here's our bone, the nerve is sliding over top of that bone, not directly over top, but there's some layers, but that friction, as it changes angles, can cause irritation to the nerve, which can increase neurogenic inflammation. All this neurogenic inflammation is mediated through the TRPV1 ion channel, which is our capsaicin sensitive channel. That's when you eat something spicy and your tongue burns, it's those receptors. So some people might know about those as the capsaicin receptors, but those are really the TRPV1 ion channels. Now, when we have this chronic neurogenic inflammation, that ion channel is going to release out things like substance P that your brain can perceive as a danger signal, which our brain perceives danger signals as pain. It's saying, hey, whoa, what's going on here? Fix this, address it, do something with it. Unfortunately, this chronic neurogenic inflammation that these nerves can get into can be problematic because at some point our body has a hard time kind of breaking that cycle, which in part has to do with low oxygen levels and actually low glucose, low sugar levels around the nerve. When we have both of those scenarios, hypoxia and glycopenia around the actual nerve, we get an increase in this TRPV1 ion channel activity, which continually dumps out substance P. It can also dump out other peptides that, neuropeptides specifically, that can actually degrade the tissue around them. And so there's some theories that some of the degenerative conditions, the OSIS conditions that we commonly treat with Prolo, PRP, stem cells, whatever, part of it is neurogenic inflammation mediated because the nerves in that area, for example, the lateral elbow, can be dumping out these neuropeptides that are then causing degeneration in that area. Clinically, what we see on that, just kind of go down that little rabbit hole, clinically what we see with that is that some patients who have the classic OSIS, lateral epicondylosis, for example, do really well with perineural injection therapy, and we can actually get a resolution of pain and it goes away despite ultrasound showing that there's degeneration or an MRI or something like that. But not all patients do, and so some patients we need to move to prolotherapy or PRP or another type of injection for the actual degenerative tendon and enthesis. But hopping back to our discussion around the cutaneous nerves. So some of the other classic things that we see with neurogenic inflammation is it doesn't typically get better with ibuprofen. And so if you have a certain pain that doesn't really, you take ibuprofen or you've been prescribed Celebrex or another pharmaceutical NSAID, you take that and it doesn't really help. It might take the edge off a little bit, but it doesn't really do much for your pain. That for me is an indication that, oh, we might be dealing with a neurogenic inflammation, kind of chronic neuropathy. However, not all patients have that. We've had some patients where ibuprofen does really well for them, but we're still dealing with neurogenic inflammation, and we see that because we actually treat with the perineural injection therapy, which is a 5% dextrose solution, and we get resolution of their pain. The other thing that keys me into maybe this is contributing to your pain is when things get worse with activity. So when we step back and think about the pathology of this for a second, we have an irritated nerve that is causing the TRPV1 ion channel to dump out substance P and other neuropeptides. There are certain things, such as mechanical friction, that will increase the neurogenic inflammation and cause more substance P to be secreted. So if a nerve is passing through a muscle or through a fascial plane, and we're getting a compression of that, which we're gonna have muscle contraction when we exercise or do any form of activity, that compression around the nerve can worsen the neurogenic inflammation. And so the patients who tell me, a good example is, let's just say with squats. I know I'm pointing at my chest, but we're gonna talk about squats. So patients who say, my back hurts when I squat or when I deadlift, actually during the movement, but then when I stop it goes away, that keys me into thinking, okay, we're dealing with a chronic neurogenic inflammation because they go into a squat, they create some contraction, either a contraction around the nerve, or they're stretching and lengthening the nerve, which is another way that we can increase neurogenic inflammation. And they then get pained with that, but when they stop and they relax and the muscles relax around that inflamed nerve, pain gets better. And so that's something else that keys me in. So if you've been struggling with chronic pain that has not been getting better with conventional treatments, physical therapy, massage therapy, acupuncture, any of the oral medications, opiates, surgery, steroid injections, things like that, it tends to get worse with activity. It's better with rest. And it is just kind of chronically taking over your life. Then you might want to consider chronic neurogenic inflammation as a cause of your pain and seek out different therapies. One of the therapies that we perform here is perineural injection therapy, which is subcutaneous injections of buffered 5% dextrose, which is going to help restore the normal activity of the TRPV1 ion channel, help restore glucose levels to that nerve so that inflammation goes down and pain goes down. And it's pretty quick and can be very effective when applied in the right patients. If you think you're suffering from chronic neurogenic inflammation, leave a comment below. Let's hop in the comments and chat. See you later.